Okay, welcome to the International GP Recruitment Programme Broadcast 3. It's the GP consultation in UK practice, and Mehreen and I are here to present it for you. So you probably remember Mehreen and I, but my name's Kim Tolley. I'm a Regional Liaison Advisor and a Training Development Manager with the International GP Recruitment Process.
Hello everyone, my name's Dr. Mehreen Tahir. I'm one of the clinical leads at NHS England for the International GP Recruitment Programme, but I'm also a GP by background in South London.
And we're here to talk about Broadcast 3, obviously, and we thought we'd remind you what we did in the last broadcast. This is the third broadcast, as we said. We looked at how Mrs. Thomas can access a GP in the NHS. We looked at the Care Quality Commission. We'll talk a little bit more about that again. We looked at chaperoning, referral waiting times, and the e-referral system. And just to remind everybody that the broadcasts are available on 14 Fish and the NHS website. They will be there soon, so they're there for you to download and to listen to in your own time as well. And this one will be as well. So just a few sort of logistical things. We're finishing at 1 o'clock. The recording, as I said, will be recorded and it will remain on the website for 6 months. Now, it's important you know that because obviously on the sidebar there is the discussion sort of part. And so it's just important that you recognise that any questions you put up on there will be on the website for a period of 6 months. And the next slide sort of talks about the general data protection rules for that, really, to make sure that you understand that. So please do ask questions as we go along. Mehreen and I will try and answer them. We've got the lovely Nick who will read them out for us. And I think that's the most important thing to say about that, really. So the next slide is just really talking about what we're actually going to cover later. But before we go on to that, we'd like to hear where you come from. Yes. And we've got a couple of polls that we'd like you to do right at the beginning. So if you want to put in the discussion board where you come from. But if we could go to the first poll, which is really Layla, which is where you're living at the moment. It'd be really helpful for us to know if you are living in England, not in England, but working as a doctor, if you live in the EEA or outside the EEA, or you're in fact from a recruitment agency. So please do poll and do click on the ones that are from you. I see we've got somebody from a recruitment agency there.
Welcome.
Welcome. I saw Head Medical. I think I saw ID Medical there as well. But if there's anybody else around, if it doesn't mind just popping on your voting, we'd be really grateful. It just gives us some really background, doesn't it? And we can think about who we're actually presenting to. Because
Kim, I know I've met a few people who in fact are already in England, hadn't really thought about this before the programme started, but they're perhaps working here in A&E locuming. So it's really interesting to find out where you're all from.
Yeah, but thank you very much. Lovely. Okay, I'm going to go to another quick poll as well, if you don't mind. And that poll is sort of talking about where you are on your international GP recruitment journey. You know, are you interested in applying? I know that from the last broadcast we had about 4 or 5 doctors who actually were interested in applying, and we were able to signpost them to the NHS England website, and that was just really useful, I think. And it's useful to have those contacts because we'd like to promote more doctors to apply to the international GP recruitment process. So to see if anybody's waiting for an interview, and I know you do a lot of interviewing, particularly you do that in London.
Absolutely. So you might be waiting for your first interview or be having your second interview. You might have had your second interview and had your offer awaiting a placement, or you might actually be on the IGPR programme. So I know it might be daunting, but it is all anonymised. So please do click on the one that applies to you. It just be really helpful for us.
Sounds like we've got quite a few curious people and people in recruitment agencies, which is absolutely fine as well. And somebody's already on the preparatory phase. So thank you very much for that. That's really helpful. So we'll go back to our slides if you don't mind, and we'll talk a little bit about what to expect in this broadcast today. So I think the slide will come on very, very quickly for you. There we go. It's coming on now. So our next slide is actually to remind you about the GMC app. It's really important to let you know about that as well. So remember to download the app. We have talked about it. We've promoted it every session we do, but we will be talking a little bit about that later on. So don't forget the GMC app. Before we start, what we thought might be really useful is just a bit of a reminder on some interesting reading and some websites that might be really useful to do a bit background reading on before you start the next broadcast. I think the first thing that I'd like to sort of point out really is the King's Fund. We talked a lot last time about the NHS and how it was funded, and it is complicated. We talked about that in broadcast 1, didn't we, really?
Yeah, and those of you who are already in the UK or working in England in general practice will know about the GP contract that we spoke on broadcast 1, and how that's all changed. And different things that are coming into general practice as a result of the revised GP contract. So that's all in broadcast 1. So please, if you haven't had a chance to have a look or weren't able to dial in, please do go to 14 Fish where it is at the moment. So if you type in 14 Fish IGPR into a search engine, it will show up.
And I wanted to talk about this fantastic free online course. The King's Fund also have got a course called The NHS Explained, How the Health System in England Really Works. It's not available right at the moment, but you can sign up, and we will send you the link after the presentation. Sign up for the free online course. You can register your interest, and then as soon as it becomes available through the King's Fund, they'll let you. It's a 4-week course. You only have 4 weeks to do it, so you've got to keep up with it, but it actually is really, really useful. So fantastic free online resources available for you. Remember in Broadcast Tour we talked about the reception area. We actually talked about it in your practice, Mehreen, didn't we? And we saw and spoke to the receptionist. I just wanted to did a bit of research really about the Patients Association, and thought you'd like to know what patients think about reception areas in general practice. The Patients Association is a really important sort of organisation. It's a charity which represents the views of patients. And they did a report actually in January this year, so a couple of months ago. And they asked patients, they did focus groups with patients and asked them what they wanted out of their GP premises. I've just picked a couple of, it's about 6 or 7 pages long. It's a really good report to read. They talked about better signage and knowing which room to go to, because I think it's quite complicated in GP practice when you sit into the waiting room, you're not sure where to go. They felt concerned about confidentiality, and I know it's something that we've talked a bit about, Mehreen, isn't it really? And they talked about difficulties moving around the building in wheelchairs. So they made some recommendations, and I thought they were actually really, really useful. But I thought we'll talk about those in a second, but they asked patients what changes or improvements they would like to see in their GP surgery building, so the physical building. I think this is quite interesting. In actual fact, a lot of patients actually didn't want to see any changes. And there was a comment which I thought was really interesting that said that patients actually feel that this is the NHS and they're grateful for the services that they have, which I thought was, you know.
And I think there's something really familiar about your GP practice. So you might be registered with a practice as a child, you might, you know, get married and have children, and your children registered there, you go there with your baby, you go there for all sorts of things, and you go on a bit of a journey with your GP practice. So it's almost that the premises become a very familiar place for you. So I know, you know, the premises for different GP practices vary across, you know, the whole of England, but there's something quite special about each one of those. So have a look at where you are, and talk to the staff about how it's changed. You know, accessibility's improved, for example, so you might find a lift in a practice that there wasn't. But it's quite an interesting part of general practice, and if you ever become a partner in a practice, the GP building is actually going to be quite an important thing for you to understand.
And I think here this was interesting. The report sort of looked at what the future might look like. I think everybody agrees that GPs should be local, obviously, but they should be bright and inviting. And I think we saw a practice that it was quite a bright and inviting waiting room. But the confidentiality is a real issue. And I know in a lot of GP practices, Mehreen, I'm right in saying that the reception area has like a line.
Yeah, so we have that in our practice. So we have a line, it's about 1.5 meters from the front desk to try and ensure some confidentiality. We have lots of signs up saying, please respect other patients' confidentiality when talking to receptionists. So stand behind the line. And also, for example, we've moved our receptionists and admin staff who answer telephones outside a reception area, so in a separate room, because we recognise actually you as a patient you could hear conversations on the telephone. So I think lots of different things are being done as we recognise some of the issues that we have in GP premises.
But it is difficult in structural, you know, when you're dealing with some of the premises are older buildings, so it's much more difficult to make those changes, isn't it really? So Wi-Fi, most NHS buildings nowadays will have free Wi-Fi, and some of them have computers within there. I know yours has a computer. Patients can look up health promotion, health advice, can't they?
And I think that's the way general practice is going. You know, we need to encourage health, you know, patients to self-manage and health promotion, and you know, having a TV screen running some useful sort of videos about different aspects of health, such as diabetes and weight loss, and you know, having access to the internet for our patients is really important.
Yeah, and we've the environment needs to be adapted and made sure. Obviously, accessibility is really important for disabled and long-term conditions such as dementia. And also, I think it came up in the last slide, but parking is always a problem. I think schools and medical centres are always a problem with parking. So parking always comes up and it's an issue that things can improve. I think the next slide is a really important one as well. I think we talked about the Care Quality Commission last time, and certainly this is a really good booklet to read, what to expect from a good GP practice. I think it's really a really nice one that I wanted to mention to you. And the next slide is actually a patient survey. So the patients every year have an opportunity to do a patient survey. It's a national thing. Your local practice will also have their own patient survey, but this is a national one. And I think it's quite interesting that 84% of people who come to GP practice are happy with their experience, which I think is pretty good. I think interestingly, 54% of people say that they want to choose which GP to come and see. And whilst a lot of the 54% of people want to choose a specific GP, actually only 50% of them get to see that GP, because it's difficult, isn't it, within constraints of appointment systems.
Absolutely. And I think for patients, we're trying to cater to urgent and non-urgent problems. We have special appointments, as I mentioned in one of the previous broadcasts, for say diabetes. So you might need to see a particular GP who has an interest in diabetes, who's been allocated as the lead for that practice, for example. And all those things become difficult when you're trying to schedule all these patients into all these different doctors and healthcare professionals' appointments. So we recognise that actually patients can't always see who they want to see, but it's also, reassuring them that actually you work as a team, and actually if a discussion needs to happen between GPs, it does happen. So that it's a lot about educating the patient. But I think it's really telling actually that 84% of people had a good experience, and that makes me really happy. I think we're going to go on to talk a little bit about consultations, but personally I think the consultations that are happening between the doctor and patient play a big part in that. So patients who are satisfied will overlook perhaps some shortcomings in a building, for example, in a premises, and the fact that it took them a while to find parking. So actually your GP consultation is really powerful and a really important part of their overall experience.
And lastly, it said that 70% of people actually found that access on the whole was actually fairly good, which is pretty good actually.
Yeah, and we talked about different initiatives like the new app, the patient access app, where you're sort of booking online, looking up results online, text messaging services, and all these new digital advancements are helping patients access without having to just traditionally pick up a phone or walk into their surgery.
And the next slide shows, I think, the rating of care at the last appointment. So patients are actually asked specifically to think about their last appointment. And again, they're good results, crikey. 89% of people felt listened to, 87% felt they had enough time. We're actually going to talk about the time of GP consultations and the 10-minute constraints that has. 87% of people felt they were treated with care and concern. And I think actually we're going to cover 93% of people wanted to be involved in decisions about their care. We're actually going to cover that quite a lot in the next broadcast. But that is really fundamental to patients being involved in their care, isn't it, in the decision making.
It's really important, and we're going to talk about that in the next broadcast, but also touch on it when we talk about consultation models in this broadcast.
So it's not all good news in the NHS, but those are some of the good news stories, which I think is quite nice.
But all of that data makes me quite proud to be a GP, and actually yes, general practice in England can be stressful, but actually it's quite rewarding when you see results like that, and actually patients are satisfied on the overall. So
we're going to go to Nick and ask Nick if there's any questions coming through, or perhaps if there's any doctors saying where they're coming from. It would be quite useful, Nick. Is there anything you wanted to ask us?
Yeah, there's no questions come through, but Elise and Leah from France, who are already living in London and on the IGPR program, say hello.
I think I met you last week in some training, and I'm sure Mehreen has as well.
I've met you both as well. So welcome. Thank you for joining us today.
Yeah, it's really nice to hear you.
And please do ask questions. No questions are silly questions. So please do use the discussion board to put out any questions, and Nick will use the next opportunity to ask them.
Lovely. Okay, we're going to actually look, we're going to go back to Mrs. Thomas now. So we met her in the first two broadcasts, didn't we?
So our broadcasts are following Mrs. Thomas's patient journey, and we're sort of using her journey in general practice to try and highlight and talk about some of the things that you might not know about general practice in England. So in our previous broadcast, we met Mrs. Thomas. She had a breast lump. She's gone to see her doctor, Dr. Kowalski, and she was referred to a specialist. So in this clip that we're about to show you, she's coming to see Dr. Kowalski 5 weeks after her mastectomy.
So we're going to show you a quick clip now, about 8 minutes long. Okay,
so thank you for listening to that video. All these videos are available, and we'll send you out a link. So if you want to have a look at it again, then please do. But we're going to talk a little bit about the consultation. So I feel like the foundation of general practice is all to do with the relationship we have with our patients, and how do we establish that relationship? I think that's through effective consulting. And I think because we recognise this and actually realise that the consultation plays such an important part in the overall experience that a patient will have, lots of work has been done on developing some consultation models. So consultation models, they look at the consultation in slightly different ways. So some are more task orientated, so they've recognised actually there's certain things that you need to achieve in the consultation, and they'll focus on that. Some are focused on time and how the consultation moves through time, and some work on establishing a really good doctor-patient relationship by looking at the patient's perspective of the consultation. And these are the four. There's lots of different consultation models, but these are the four that I have spent most of my training and life as a GP revisiting and learning about. And the Calgary-Cambridge consultation, I feel, is probably the one that the Royal College of General Practice use most when they're trying to develop mark schemes. So, for example, if you have a simulated surgery, or what we call a clinical skills assessment, which is a range of consultations when you're assessed, I think that the Calgary-Cambridge consultation model probably mirrors quite closely the mark scheme. So that's probably one, if you're going to go and read, I would go and read about. But I will just spend a couple of minutes, if that's okay, just telling you a bit more about that model. So the Calgary-Cambridge model has 6 components. The first one is initiating the session. So in the video that we just saw, Dr. Kowalski, she's met Mrs. Thomas before. She already has a relationship with her. And I think it's quite important to recognise that. So when you meet a patient again, sometimes you might not actually remember them or recognise them, but we're lucky we have our notes. So I will quickly have a scan of the notes before the patient walks in, and to remind myself of why they've seen me in the past and why they might be coming to see me again. And a simple phrase phrase that Dr. Kowalski used, like, good to see you again.
It's nice, isn't it? It forms a really, it's recognising that she's met her before.
Absolutely, and it helps with establishing that rapport again. It's quite important to identify the reason for the consultation, and I'll talk a little bit more about that when I talk about how I conduct my 10-minute consultations in a minute. But the next part of the Calgary-Cambridge model is gathering information. So this means exploring the patient's problem, but remembering actually what is most important is a patient's perspective.
So it's very interesting what Mrs. Thomas straight away, didn't she? She talked about wanting to get back to normal, wanting to get back to work, wanting to talk about that. So she'd obviously been interesting. She'd been sitting in the waiting room thinking about that, hadn't she?
Yeah, and actually, do you know, even being a patient myself, and I'm sure you've all been in this position before, you do sort of write a script in your head of what you're going to say when you go into the GP, because you recognise actually time's a limitation, and you might be stressed about what you need to say. You might be worried about whether the GP is listening or understands what your problem is. So the patient's already started their consultation journey with you in the waiting room, and it's really important to remember that, even when you might be running late, or you've got messages coming in from admin, or you might be duty doctor. Just remember what it's like for the patient. And I think these models really lend well. They really lend well to remembering that the patient is the centre of all the consultations. So the third part of the Calgary-Cambridge model is about building a relationship, and this doesn't have to be through verbal communication. So we've talked about how using empathic statements and saying good to see you again, reminding the patient that actually you do know them already and you've been on this journey with them already. But it's also about using non-verbal behaviour.
It's the way she sat, wasn't it?
Yeah,
the way she was very open.
Yeah. So mirroring, turning your chair, direct eye contact, sometimes if it's appropriate, a hand on a hand, if it's something very very emotional that you're talking about. All these non-verbal cues patients pick up on.
It's quite difficult, isn't it, when you've got to look at the screen, because you've got to look at your screen sometimes to get information about what medication they're on. It can be quite distracting, can't it, really, for patients?
Absolutely. I mean, everyone's got their own style and technique, but I do move my chair around, and because we're lucky to have swivel chairs, actually, it's very quick to say, I'm just going to quickly have a look at your medicine, so they know that actually you're not removing yourself from the discussion that you're having, you're just referring to something that you need to see to progress that consultation. The fourth part of the Calgary-Cambridge model is about providing structure. So I'm going to talk about the structure that I have, which is largely based on these four models, but just putting out to the patient that actually the consultation is going to go somewhere, and that there is going to be an end point. So, for example, Dr. Kowalski will say, I can help you with that, we can talk about that and sort that out for you. So the patient's reassured that they're going to get something from the consultation. And then I think the most important part of this model is about the explanation and planning. So sometimes it can be difficult when you're rushed to find time to just explain what your thoughts are. The patient might be asking you for a diagnosis, just explaining what that diagnosis, and one sentence just to say what it is, which allows you to have that discussion about management options, and make sure that the patient understands. So when you close a session, which is the final part of the Cambridge consultation model, sometimes just checking in with the patient to saying, so Mrs. Thomas, you've told me that you want to go back to work because you're worried about sick pay, and also you want to get back to normal, and we've talked about how a fit note might help you. Can you just check that whether there was anything else that you wanted, or that you've understood what we've talked about? Have you got any questions? And that's really reassuring for the patient. I mean, 10 minutes to take in all that information it's hard for patients, and that's why I often provide written information as well. So if it's perhaps like an elderly patient who's worried that her daughter won't understand what they're saying, sometimes I write a few bullet points on a post-it note. So I do have a big mound of post-it notes, and I use them a lot. Printing out a patient information leaflet. So actually, a lot of our IT systems, they come up with an automatic link to the patient information leaflet when you type the problem into the consultation. Print that out, give it to them. At least they've got something to read. For asthma, written action plans. All those sort of things. So I'm having some sort of point of closure, so by handing them that leaflet, and also planning forward. So say, look, I've given you this leaflet, or I've given you this fit note, Mrs. Thomas, it's going to run out in 4 weeks. In 4 weeks, you said you're going to try and go back to work, and you have a chat with your manager, but why don't we book a follow-up appointment in a month's time when we can have a chat to see where you are and see whether you need any more support or help? And I think that's a really important way of looking at the consultation. I mean, I've written about 3 other consultation slides. So please do go and have a look at them, have a read of them, talk to your supervisor about them. It's often been quite a while sometimes, and some GPs have sort of revisited, but they are a really good tool for reflection. It's a really good way of looking at your consultation. And really it gives you a sort of a template or an outline of how you can analyse what your consultation looks like. So like I said, I've put up what my 10-minute consultation looks like. So 10 minutes by the GP contract is sort of a minimum length of consultation recommended.
Patients can book double appointments, can't they, if they want to,
absolutely,
with a receptionist, etc.
Absolutely. So you can request a double appointment. Perhaps you need a translator, or perhaps it's for a coil fitting, in which case you might need 25 minutes or 30 minutes. So that does vary, but on the whole, your consultation will last 10 minutes. So how do you structure that 10 minutes? So I talked about the patient's agenda. So you'll hear a term, ICE. So ICE stands for Ideas, Concerns and Expectation. It's something all GPs in England, I think I can safely say, know and hopefully practice. So just breaking it down. So for example, Mrs. Thomas' ideas were that she doesn't feel normal and she wants to get back to work, and she's not quite sure how to do that, and she's also worried about sick pay. And her concerns are that actually going back to work, she's going to be worried about feeling tired and about the commute and the long days. And her expectations might be that you can sort of give her some advice about how she might do that, or whether she should even go back to work. And I think if you don't manage to cover these quite early on, sometimes the consultation can become quite difficult.
So you need to use those to structure as well within it.
Absolutely. So
get to the nub of the problem, sort of thing.
Absolutely. And the patient might have a completely different expectation to what you perceive. So sometimes just asking the patient, so what were you hoping I can do for you today, is really useful. And then I use the golden minute. So you'll see that when Dr. Kowalski in that video welcomed Mrs. Thomas, she allowed her to speak for just over 60 seconds. And the wealth of information and the amount of information that Mrs. Thomas divulged in that minute was priceless, really. It saved a lot of questions, and it sort of set the scene for the consultation. So it can be hard not to interrupt when you're rushed and you just want to, get to the nub of the consultation, which is for us sometimes what they want us to do for them. But allowing them to speak is really important and actually really valuable. And then open-ended questions. So questions.
She said things like, "How do you think you'll cope?" Didn't she? And she said, "What does your job involve exactly?" So very open. Get more information from Mrs. Thomas.
Absolutely.
Yeah.
So open-ended questions are really useful. And there will be times, like for example, when you're trying to make sure that there's no red flags.
Yes.
When you have to ask closed-ended questions. So more direct questions, if you like, which might have yes/no answers. And for those of you, I'm sure most of you know what red flags are, but they're sort of signs and symptoms of conditions which might suggest there's something more serious going on, like a cancer. So it's important when those sort of issues arise in consultations that you address all the red flags. And even medico-legally, when you're documenting, you should really be documenting that there are no red flags and what those red flags were, and that you've discussed them with the patient. And then safety netting, so telling the patient about what to do should something go wrong and what those events might be. So for Mrs. Thomas, you even in this scenario, you might say to her, actually, Mrs. Thomas, if you have any problems, even with the late starts and the phase return, or actually you find you're getting more unwell, but actually develop any new symptoms, because she has had breast cancer before, she's had a mastectomy. If your wound gets pussy or red or sore, then actually I'd like you to come back and see me, and probably request an urgent appointment if that happens. And if it's a weekend, please call 111, and actually you can see a GP on the weekend and out of hours. So giving them some safety netting advice as to what to do should anything not go to your plan. And like I mentioned before, follow-up plans are really important. Use written plans whenever you can, and then summarise. So I always summarise the consultation, even if it's a 10-second summary, saying, okay, so Miss Thomas, she came in for a fit note, and that's going to hopefully help you get back to work. And I've given you one, and we're going to catch up again in 4 weeks. So that's how I structure my 10-minute consultation. But as you start, practicing more within 10 minutes and within the sort of general practice framework that we have in England, you'll develop your own style and things that you will always do in consultations.
So you almost develop your own model, really.
You do. So my model actually is based on those 4 models, but I've just picked the bits that work for me and my patients.
And I like the idea you told me earlier that you actually, when you first started, you had it printed out and up on your wall.
I did.
So if you got stuck with patients, you knew where to go.
Because you can be in the middle of a consultation and think, what does the patient come to see me about, and how are we going to move anywhere? And actually just looking at it and thinking, okay, so really we should be talking about some red flags, or and asking a few more open-ended questions rather than closed-ended questions.
Okay, so I think we wanted to give you some pointers for how you could improve your communications and consultation skills, really, didn't we?
Yeah.
So work-based activities. I know, Mehreen, you do this a lot. Video. You when you were learning, you used to video your consultations.
Yeah, so video them, and then you can sit down with your supervisor and colleagues and just analyse them again using perhaps some of those models that we know about. Your supervisor might want to come and sit with you in a surgery, which I think is really valuable. Can be quite daunting, but actually you get a lot of useful feedback from doing that. Looking at random cases with your supervisor or colleagues, reflecting on cases. So reflection is a big part of our sort of practice in the UK as GPs. We're going to talk hopefully in a further broadcast about the importance of reflecting and how that is incorporated into your professional development and appraisals and revalidation. You'll all have to do some work-based placed assessments as part of the programme, but they're really useful tools for looking at your consultation and looking at the skills that you have. And patient feedback questionnaires, they're really telling. So again, we will talk about them in a further broadcast when we talk about revalidation and appraisals. And then you'll have the opportunity to go and sit with different GPs. And like I said, there's no correct way or wrong way of consulting, but everyone has their own style, and different things work for different people. So go and use this opportunity in the programme, especially in the preparatory phase, to go and see different GPs and different healthcare professionals consulting. And then you can do some things of your own. So there's lots of websites where there's little synopsis.
Great role plays.
Yeah.
Great sort of synopsis for role playing.
Absolutely. These different scenarios where there's a doctor and a patient, and in small groups, you can practice some role playing and give feedback to each other.
I think particularly with your IGPR colleagues it'll be really useful. I know I've got a couple of colleagues that have called in who are on the programme. I think to get together, in an evening when you can, and actually have a go. I know it feels a bit false initially, but you learn such a lot from each other, don't you, really?
Absolutely. Yeah. And I'd go and encourage you to read about Balint groups.
Yes.
So Balint groups are really interesting. They are sort of peer group learning, but they have a bit of a different focus. So they talk a lot about how a patient made you feel, or a certain consultation made you feel as a doctor. And I've been in a Balint group before and found it really valuable. So if you Google Balint group, there'll be a full explanation of what they are. And then of course there's courses. So you remember, consultation is not just face to face. You have telephone and video consulting as well. And there are new courses out which will help you develop skills to work effectively within those different types of consultation.
Being a nurse, I would say learning from the multidisciplinary team. So going and watching how the nurse structures their consultation, because they'll be very similar. They use very similar methods.
Absolutely.
And just watching and learning and observing how other people, and picking up tips and cues. I think one of the best ways to learn is to role model somebody who you admire and how they do it. So it's really nice.
Absolutely.
Yeah. Okay, so Nick, any questions?
Yes, we've got a question from Karen from France. How do you manage when patients have 2 or 3 motivations or reasons for consulting?
That must happen.
And how often does it happen?
Yeah, so it happens a lot. I think it does vary a little bit on where you practice. So some patients are really well, I want to say educated, but they've been told that actually, a 10-minute consultation is for one problem, and they will stick to that. But on the whole, I think you can expect somebody to come in with 2 or 3 problems. And I think, remember that it's not just that 10-minute consultation that you have the luxury of. You can ask them what their 2 or 3 problems might be and quickly work with them to work out which one you're going to address in that consultation. Right. There might be something actually that they think is not important, but actually might be a red flag for something, such as bleeding from the back passage or, feeling low, which you probably can't leave and you need to deal with in that consultation. But reassuring them, actually, we can book another appointment to talk about those other problems, or actually, you wanted to perhaps talk about a gynae problem, why don't you book in to see me? But in the meantime, book in with the nurse and get some swabs done. So actually we'll have some results when we talk about that other problem. I mean, some GPs everyone works differently, and some GPs would address those two or three concerns within the one consultation. But it just depends. I find using a follow-up, using some interim things that you might had needed to do, usually works. And patients I've touch wood, not had any complaints about it before, and patients usually are quite happy.
And I know you also mentioned that sometimes you don't know all the answers, so you can say to the patient, I'm going to go and talk to my colleague, I'm going to go look this up, and I'll phone you later or tomorrow.
Absolutely. And
patients are all right about that?
Absolutely, that's a normal thing to do. Rather than give people inaccurate information or give them half of the information that they need. Patients are quite happy for you to say that actually I'm going to book you a telephone call in the afternoon, and once I've spoken to one of my colleagues or just had a bit of time to look that up, then I will I'll get back to you.
Any other questions, Nick?
Rob Kilty is asking, how do you handle the door handle problem?
Is this sort of somebody just going out the door?
At the door, yeah.
So Rob, this happens. I'm sure it happens to you quite a lot in Australia, but it happens to us a lot. Sometimes, unfortunately, you can't ignore what they've told you. So as they're leaving, they say, "Oh, by the way, I've lost 3 stones in a month," or you can't really leave that. So sometimes I will call them back, but sometimes if it can wait till tomorrow or wait till the afternoon, then I do rebook a consultation for them. And I think patients are quite happy actually when the GP says, actually, I'm going to book you an appointment now. You're going to come see me tomorrow at 1:30, rather than say to them, go out to the receptionist and get another appointment, because they can sometimes find that a bit of a challenge. But I suppose, for safety reasons, there's some things which you can't ignore, and unfortunately you will overrun and be late, and you have to deal with it there. But you have to make a quick assessment, don't you? I'd be interested to hear how you all deal with that, because I'm sure wherever you're practicing, you do get patients walking out the door dropping a bombshell on you.
So if anybody's got any tips, add them to the discussion board. That would be really helpful. I think everybody's learning, aren't they?
Absolutely.
Okay, we're going to go on now to the GP's role in a patient returning to work. Now, Mrs. Thomas is talking to Dr. Kalowski and wants to return to work. And actually, we were talking about returning to work. Work is a really important part of people's lives, and actually has a huge impact on people's mental health, mental well-being. And actually going to work is fundamentally. And interestingly, we're going to talk about getting the most out of your fit note. There's some fantastic guidance at the Department of Work and Pensions that we've put up there, but I think everybody needs to know that it used to be called the sick note. So we're trying to get away from this sort of negative image of people being sick, which everybody is obviously, but it's about helping people to get back to work. That's the most important part of it, isn't it, Mehreen?
Absolutely. And I know the fit note might be something that a lot of you are not familiar with, because I do know it is quite unique to England. And so I would encourage you to go and read this guidance about what it is. But I will use the next sort of couple of minutes just to summarise the guidance and to give you a bit more information about what the fit note is. So you'll see that in the video, Mrs. Thomas was offered a fit note by Dr. Kowalski, and she's got some amended duties on there, which I'm going to talk about. But I think the GP has a really important role in providing simple return to work advice, and that's why this guidance exists. Return to work is a really important health outcome.
Definitely.
And I say that to my patients all the time, that actually I know you might not feel, you might be feeling really low and don't have the motivation to go to work, but once you're out of work, that return to work becomes harder and harder the longer you leave it. And I want to do everything I can to help you get back into some sort of work in some sort of form, because it's not good for their physical or mental well-being at all. I mean, the fit note, it's a sort of way of helping you have that discussion with your patients, because it is a difficult discussion sometimes. And it helps you reinforce that actually you don't have to be 100% well to do every job. And actually the advice that you're giving isn't job specific. You could do lots of other things. It doesn't have to be that one job that you were doing before. And it also helps patients have that conversation with their employer, because again, that's a very difficult conversation. But if you've clearly documented how a patient's health is having an effect on their functioning and their ability to do ability to work, that's there in black and white, and it facilitates a much easier conversation between the employer and the patient to accommodate their return to work.
Yeah, and the next slide, doesn't it, talks a little bit about some of the guidance really, and the importance of that guidance to manage Mrs. Thomas's expectations really, and it gives you an opportunity to do an assessment, doesn't it, about their condition and fitness to work. And I think we've already talked about also thinking about how she might be supported to go back to work, because that's, you know, it's important. If you've had an operation, or Mrs. Thomas has had a mastectomy 5 weeks ago, it's had a massive impact on her, not only physically but her mental well-being as well, and how you as a doctor can support her in that.
Yeah, and again, that fit note, it works as a sort of tool or a prompt, if you like, for you to actually give her that information and signpost her to all this other support that is actually out there, but you may not have thought of, or the patient may not have thought of. So I thought I'd tell you a few important things about who might need a fit note, because there are quite a few misconceptions that exist, and
patients have misconceptions about if they minor illness and they're off work for 3 days, they can actually self-certify themselves.
Absolutely. So for the first 7 calendar days of any illness, a patient does not need a fit note. They will be asked by their employer perhaps to sign a form called the SC1 form, because they can self-certify to say that they've been unwell for the first 7 days. So if a patient comes in and asks for a fit note in the first 7 days, you don't need to issue it. Legally, it's not required. And if a patient perhaps has had a fit note which has said they're not fit for work, but then they are better, and they do need to go back to work, you don't need to recertify that then they are now fit for work. It's purely to say that people are not fit for work or may not be fit for work, and I'll talk about whether what may be fit for work means. But your assessment about whether your patient's fit for work is about, for their, like I said earlier, for their fitness to work in general and not specific to their job. So you might have a builder sitting in front of you who's got a shoulder injury, but you're not assessing whether it's safe for him to go climbing ladders because you're not occupational health, you are a GP. You're just telling the employer about things that he can't do, and that is then it's up to the employer and their own occupational health within their own workplace to make that assessment. So you can talk about functional limitations. So for example, their stamina, they might be better in the morning than they are in the afternoon, or vice versa. They might have something like rheumatoid arthritis. The duration of their health condition. So is this something that we know is going to get better? Like if someone has fractured their ankle, we know that hopefully eventually within 6 months they will start walking. But actually that might fluctuate. So if they've been on their feet for a long day, for a whole day, they might actually then not be able to be as mobile as they were the next day. Is there any work that they might make their health condition worse? And that's quite important. Or are they on any treatment which might affect their ability to work?
So Mrs. Thomas, for example, she's not having chemotherapy, but if she was having chemotherapy, some patients do work during chemotherapy, but it's important to think about how that impacts on her tiredness and the fact that she's more susceptible to infections, for example.
Absolutely. So these are all important, all things which are really important when filling out a fit note. But there is an option on the fit note, and I will show you a sample where you can tick where it says may be fit for work. So I think here's a sample, and this is intentionally blurred, so you will not find an empty fit note, hopefully, on any sort of internet platform, and there will always be blurred because obviously this is a legal document. But this is generally what a fit note looks like, and you can see there was a big white box there with 4 little tick boxes in. That is the maybe fit for work box. So when you fill out a fit note, the second box there, that's where you write the date, and then in the box below that there's you're asked to put an accurate description of the patient's condition.
And I was going to ask you, because I've heard this from some doctors I was actually teaching, they were concerned, how do you get around, or how do you work with a patient if they have something they don't want their employer to know? For example, if they had a mental illness that they didn't want their employer to know about, or they were depressed and they felt uncomfortable about you writing that down on a form. How does that work?
So that's really common, and actually I always have a discussion with the patient about what would you like me to write in that description box, and obviously it does have to be accurate, you can't lie. But for example, for depression I might write low mood, which is accurate, but some people might feel that having stigma,
isn't it? Although people need to realise that actually the employer can support people.
Absolutely. And sometimes I've actually encouraged patients to allow me to write a bit more in there, because I remind them, actually, this fit note is going to help you have that discussion. And actually, it might be better to tell your employer exactly what's going on so that they can try and help you stay in work. And then, as I mentioned, the tick box. So there's a tick box for not fit for work, and then you tick that, and that's all you need to fill out in terms of the illness. Or they may be fit for work, and that takes into account 4 different recommendations that you can make. So the first is a phased return to work. So that's a gradual increase in work duties or hours, and that's what we've suggested for Mrs. Thomas. Altered hours, so you might suggest a change in time or how long their day is, because that might be impacted by their illness. There's also a section on so workplace adaptation. So you might ask that perhaps they work on the ground floor rather than the first floor of an office because their mobility is reduced, perhaps after that ankle fracture. And there's also amended duties. So, for example, for that builder, you might ask that actually should not be carrying out any physical work, on ladders. So you could, and then it's up to the employer. Perhaps you could do some back office work. And if you do tick one of those 4 boxes, then you must complete the comments box underneath. So there is a comments box, and there you're asked by the Department of Work and Pensions to put as much detail as you can about what those altered duties or phased return of work might look like.
And it is important, isn't it? Because some of it's about sick pay, isn't it, for patients?
It is. So the patient will use their fit note in different ways. I mean, on the fit note, there is an area where you have to write the time that the fit note applies for. So it might be a specific end and start date, or you can tick, 4 weeks, for example. And then you need to indicate whether they need an assessment at the end of that period. And make sure you hand sign them. So I should say that all practices now have the ability to computer generate them. Generate the fit notes, and that's really important because it allows one to see if duplicates can be printed by admin staff. It allows some continuity of care, so you can have a look at whether the fit notes have been issued in the past and what's been written on them, and if there's a pattern emerging. For legal purposes, it's better that they're computer generated and they sit on the system. So do go and have a look at yours, but you still need to print it out and hand sign it and make sure your practice details are on there. So I mean, on this slide you can see what patients might do with their fit notes. So if they're employed and not fit for work, then they would claim sick pay. If they're unemployed, actually, they become entitled to certain health-related benefits, and we could do a whole broadcast on the social care system and all the different benefits that are available to them. But
complicated.
It is, but the fit note does play a part in that. If they're employed and they may be fit for work, as is Mrs. Thomas, then actually, like I mentioned before, the fit note's a really useful tool to facilitate discussion between the employer and patient about changes that might help them return to work, such as Mrs. Thomas starting later because she wants to avoid the tube, altered hours, recognising that she's going to be tired. But for some other people, it might be working from home. So I think the fit note is really valuable, but used correctly. So go and read that guidance. It'll give you a lot of information. But there is another option. So if you're issuing a fit note for more than 4 weeks, perhaps, or you're unsure and you're not quite sure about how to fill out that fit note or how a patient's health is impacting their ability to work, you can refer your patient to a Fit for Work programme. There's an excellent website, www.fitforwork.org, and also an advice line which you can call. And what they will do a bit more of a thorough assessment, because we're not trained in occupational health unless, some GPs are, but most GPs aren't. But they will do a more thorough assessment and they'll devise a return to work plan, and that takes the place of any more fit notes. So you won't be asked to issue any more fit notes, and they'll have techniques and different tools strategies, to try and facilitate return to work. Because, like I said, we know that it's a really positive health outcome, and it's better for the patient in the long term if they return to work.
And hopefully Mrs. Thomas will return to work. We might see what happens later.
Absolutely.
Yes, definitely.
So you'll see.
So we're actually going to just play a very quick video and listen to what Mrs. Thomas thinks about after the consultation. Okay, so it's just nice to hear from Mrs. Thomas, isn't it, about how she feels that relationship. And I think the best interest comment's really important, is it really? Because you have her best interest at heart. So, Nick, any other questions?
There's no questions just yet.
Fantastic. Okay, that's brilliant. Okay, thanks, Nick. That's lovely. So I think what we wanted to do is prepare now for the next broadcast. We've actually covered a lot in this broadcast, a lot about consultation, a lot about structuring your consultation, and an awful lot about sort of fit notes. And I was going to ask you, Mehreen, about how many fit notes do you reckon you give in a week or an average week?
That's an interesting question. So say in a day, again, it depends on your the demographics of your patient. For example, so I was working 2 sessions yesterday, and I issued 1 fit note actually.
Oh, okay.
But I use the third, what we call the third sector, which we will talk about in one of our following broadcasts. So charitable organisations and social prescribers. I use those organisations quite a lot, and so I refer patients to them. Yes, I referred someone to a befriending service, so an elderly lady who was becoming quite lonely and depressed. I referred her to a charity locally where they match you up to another elderly person and set up some sort of coffee mornings and meetings for you, just to help with that. So I use those sort of opportunities a lot, so I think that probably reduces the number of fit notes that I issue.
It's interesting, isn't it, really? So we're going to cover the GMC, we're going to cover confidentiality a lot in the next session, and also the referral, and we're going to look at the role of other health professionals when caring for Mrs. Thomas, but also caring for her son. So it would be super helpful if you'd have time to read the GMC confidentiality guidance. It's called Good Practice in Handling Patient Information. I would say it takes about 20 minutes to read it from cover to cover. It's not a huge read. Again, you can go on our website and request a publication. So if you want to, just go on our website, type in GMC publications, and you can actually ask get a free postal service. So we actually send one to your home address, even if it's abroad. So do that. So that would be really, really useful. So please try and read that for the next one. The next date is actually on the 6th of June. From 12 to 1, and we're going to talk about the GP looking after the whole person, and we're going to look at Mrs. Thomas, her son, and what happens next in the scenario, which would be quite interesting, really, I think, because I think general practice is not just about looking after Mrs. Thomas, and you're going to see her son and what happens when her son comes in, and you obviously, the role of carers, the role of relatives, and is really important.
Really important. And I think when you do talk to your supervisors about the consultation models and the consultation, you'll hear something called a biopsychosocial model. You'll hear about that, and that's about considering the patient as a whole. So considering what impact their illness or their health is having on their living, their people around them, the home that they live in, the work that they do, and actually the people around them are really important, especially in cases like this, where actually they might require some care later on in life. So I think that's one of the things I love about general practice, is actually you get to know families. The other family member might not be one of your patients, but actually they're a relative of your patient, which for me is as important.
I was met a GP the other day who was telling me that he was caring for a child that he'd actually been involved in delivering. So how bizarre is that? He was called suddenly to somebody's house for an emergency delivery, and blow me down, he's now looking after that lady, and she's having children of her own, which is a real privilege, isn't it, really?
I mean, I had a patient yesterday who I saw when she was trying to conceive, and been trying to conceive for quite a few years. We did a few simple things, putting on thyroxine, interestingly, I was doing her 8-week baby check yesterday. So it's great when you're in a practice and you see patients on their journey, meet people like Mrs. Thomas. It reminds you why you became a doctor.
And that's a real privilege, isn't it, really?
Absolutely. And I know some of you have asked about where the broadcasts are. Like I said, they will be on the NHS England website very soon. The second one will shortly be up on the 14 Fish website. I know the first one's there already. So in a search engine, if you type in 14 Fish and IGPR, that will take you to a direct link to the broadcast. If you're interested in looking at Mrs. Thomas's video, they're actually on YouTube.
Yes, we can send them the links, can't we?
We'll send you the links. So if you want to watch the entire journey, then please do. And actually, I'd like to plug our 360 virtual reality video. So actually, you can be in the room with Mrs. Thomas.
Yes, you can.
So we will send you instructions on how you can access Mrs. Thomas's patient journey through virtual reality. In a following email, but this will allow you to be with her and see some of the upcoming videos that we're going to be showing you on these broadcasts through an app on your phone actually, and if you're interested, with some 3D glasses.
Yeah, certainly we've got a system, we're just developing a system now where we'll be able to give you the link again and give you an address where you can just email us, and we'll be able to send you some cardboard Google glasses, which are a relatively cheap way of just watching the video, 360 video on your phone, which is pretty amazing.
It is amazing. So that video where you saw Dr. Kowalski and Mrs. Thomas having that conversation about the fit note, if you wanted to, if you turned around, you'd see Dr. Kowalski's couch, you'd see her room, you'd see all the different things. You can look around the waiting room. You can meet a pharmacist. So we will send you all those instructions. And, you know, before the next broadcast, before the 6th of June, why don't you all have a go on the virtual reality video, meet Mrs. Thomas, be in the practice, you know, write down any questions that you have, ask me about them, be there about the premises. We've talked about the GP premises today, so if there's anything odd that you can see, and
have a look around your waiting room, because that's quite
and I
interesting,
challenge you, we have some interesting things in our waiting room, so have a look, and then let's talk about them in the next broadcast.
Yeah, that'd be really nice. So we will send you all links, and all the information we've got. We'll send it to all to your emails that we've got, but we want to ask you finally how you'd rate the broadcast. It's really useful for us to know whether you think it's good, either good nor poor, or very poor, or you don't want to vote. That's fine as well. So it's really helpful for us to know that, and it gives us sort of clues to the fact that, are we doing the right thing? Some of your comments, I'm just glancing at some of your comments to say, and they're really nice. So thank you for being so positive in your comments. We hope that you're enjoying it. We're certainly enjoying talking about GP practice and introducing you to Mrs. And the last question is whether you feel that this broadcast has helped you integrate into the NHS. Now, I know that's difficult for some of you because some of you aren't yet on either the IGPR programme or not, but it's really useful again for us to think about, because that was the aim of these broadcasts. Was really, we recognised from the pilot schemes of the International GP Recruitment Programme was that some of the things were concerning you were the NHS and how it worked, and also the GMC guidance. So that's why we keep referring to those things in the programme.
And absolutely, and like I keep talking about, the programme is fantastic for integrating you into the NHS, the International GP Recruitment Programme, which has a preparatory phase where you are really well inducted into your practice and into your local sort of NHS community, is just so invaluable. You'll get the chance to see all these things that we're talking about in practice, and this is just something to give you a bit of background and give you a bit of a head start, if you like, about some of the things you might encounter.
Yeah, and I'm just glancing, Rob. Thank you for your comments. I'm enjoying this. It's reminding me how things and showed me how things have moved on over the last 14 years. I think massive changes in the last 14 years.
And I think there's lots of changes coming. So it's a really interesting and exciting time for general practice. So I think those of you who are coming in this year, next year, you know, you've come in at the right time. Things are changing, and for me, I feel for the positive.
Yeah, and it's a real privilege. It's been a privilege with you today. We've really enjoyed it, and we look forward to meeting you again in June. As I said, Mehreen and I are really happy to take questions. If you're worried about anything, just email us. We're very happy to answer your queries, questions and concerns. So thanks a lot. Thank you very much.
And any ideas you have, then please also drop us an email. If there's something that you want us to talk about, we've still got 2 more broadcasts of this series, so we're happy to incorporate any ideas.
I think we've picked up that we'd like to look at reflection and appraisal and revalidation for one. So we picked that up from some queries and questions, but thanks very much.
Thank you.
Okay, thank you. Bye-bye.
Bye.
Bye-bye. Thank you very much. Bye-bye.
Thank you.